So a third category of immune drugs are monoclonal antibodies, and I'm going to discuss them in two flavors. One are non-checkpoint inhibitors, and the other obviously are checkpoint inhibitors. So what are these treatments? Well, antibodies are immunoglobulin proteins that are used by the immune system to identify and neutralize foreign objects, okay? And you've seen antibody structure previously. But the important thing to take home, it sort of looks like a Y. The antigen finding or binding sites are at the edge out here. And so these can basically use like traps, infuse them into the body, and they can basically connect onto things. And that can induce other immune cells to attack whatever that is, or for that, whatever it connects to actually get cleared out of the body. Antibodies, therefore, can be engineered to recognize and bind to cancer-related molecules. And so here's a pretty picture of a blood vessel with antibodies that are picking up blood vessel growth factors. So there's a drug called bevacizumab that's approved for a number of different cancers in which an antibody, the drug is an antibody that's infused that binds to a molecule called vascular endothelial growth factor A. And that vascular endothelial growth factor A, or VEGF-A, causes blood vessels to grow, and by giving the drug, you're basically depriving the blood vessels from their growth factor, and therefore the blood vessels shrink. Antibodies can also be used as delivery systems. And so using sort of some advanced immunological and engineering technology, you can make antibodies do different things, like connect a cytokine to an antibody. So it goes and sticks to something and brings the cytokine there. You can also hook on another drug. So in breast cancer, there's a drug now called TDM1, in which a chemotherapy is hooked to an antibody. The antibody then goes and finds the cancer cell and brings a very high dose of chemotherapy right to it. You can also connect on a toxin, and you can also cause it to link up to a T cell, and this was mentioned a little bit earlier with engineered T cells. You can have T cells that already have these things put on them, so when they float around, they connect to whatever they're supposed to find, and then the T cell's right there and already knows to kill the cancer. So how are these drugs given? These are intravenous drugs. Again, these are proteins, so just like a hamburger protein. If you put them in your stomach, it probably wouldn't work too well. Well, I don't know if anybody's ever actually tried that, but I don't think it would work. How often are they given? Usually given every 2 or 3 weeks. How long does it take to receive? Well, this sometimes takes a little bit longer. So often these need to be thawed by the pharmacy, and there can be a wait time in administering them. So after you see your doctor, you need to go and check in. They then start the process of thawing the drug. That can take up to like an hour sometimes, and then administer the drug, and that can take about another hour. So I usually tell my patients it takes about half the day. Do any medicines have to be given before or after? Generally speaking, no. If while they're infusing it, you have a reaction to the infusion, then obviously some drugs might be given, like Benadryl or other supportive medications. Are there contraindications to taking this? Well, that can depend somewhat on which drug that they're giving. Obviously, it depends on what you're trying to do. If you have, so if you're someone who has heart problems and then you take a drug that's going to affect your blood vessels, that potentially could be an issue. Similarly, if you have skin problems and you're taking one of these that attacks skin molecules, you may have an issue there, and that just needs to be considered before you start on the treatment. Are there any drug interactions or medicines you shouldn't take? Generally speaking, no, but this may be specific to the particular kind of drug, and your doctor can talk to you more about that. And how many doses and for how long do you need to take it? These treatments are generally given continuously because what they're doing is generally binding to things that are naturally in your body or associated with the cancer. So if you take them away, those things will come back. So those blood vessel treatments are usually given for a time period to see if they're working, and if they are, they're usually continued. What about the checkpoint blocking antibodies? So the previous antibodies I talked about are infused, they go and find and stick, and then other things happen. These antibodies are slightly different in that these checkpoint antibodies are regulators of the extent of the immune response. And they were discussed previously sort of like gas and brake pedals in a car. I sometimes tell my patients they're sort of like the switches in an airplane. Some of them are up, some of them are down to take off, and some are up, some are down to come back down. They're mostly expressed on the cell surface, because that makes sense, because the antibodies are relatively large proteins. They don't usually go in the cell, so they have to see things on the edge of the cell. And this is a figure that shows expression of, a cartoon that shows expression of PD-L1 and ligation of the PD-1 receptor. And you can see that it's on the edge of the cell. This is the cancer-fighting cell. This is a tumor cell. Expresses PD-L1 and can ligate the PD-1 receptor. You'll notice that PD-L1 is expressed actually in a number of other places as well. These are all other immune system molecules. So PD-L1 is not specific to the cancer, but the cancer sort of steals it as a way to hide from the immune system. Blocking these immune regulators, or these switches, though, can sort of titrate the degree of your immune response. So go from no response to response. And that's sort of figured here. This is an immune cell. This is an immune cell interacting with an antigen-presenting cell, or a dendritic cell usually, getting activated. But after it's activated, it expresses this molecule called CTLA4, which the drug ipilimumab then blocks, allowing the cell to stay active. So these are the current immune checkpoint blocking drugs that are in development. The first of these that was described was ipilimumab, anti-CTLA4, and that's approved for melanoma. There's another anti-CTLA4 drug that's been in development called tremelimumab that you might hear about as well. For anti-PD-1 antibodies, the two that are furthest along in development are pembrolizumab, which is now approved for melanoma, as well as nivolumab. Both of these drugs are being looked at in a number of different kinds of cancers, as was alluded to before. And there are also molecules that are designed against the PD-L1. And those don't have names yet, but if you're sort of in our field, you just roll these off the tongue. MPDL3280A and MEDI4736. This was also alluded to a little bit earlier. There are a lot of these switches in the immune system. So we've talked about CTLA4 with ipilimumab and PD-1 with pembrolizumab and nivolumab. These are inhibitory antibodies. They turn off things in the immune system. So the off switch is off, therefore the immune system is on. But there are more of these inhibiting antibodies, and it was discussed that these are in development as well. There are also activating molecules, however. And some of these are also the targets for drug development. They aren't as far along, and we don't know as well how to use them yet, but it's very exciting that these exist as well. And you can just see the potential here. So combine one from the left and one from the right, or two from the right, or two from the left. We don't really know the answer yet, and that's what research is going to be about in the future. So how are these antibodies, these non-checkpoint antibodies, these checkpoint, this should say checkpoint, I'm sorry. How are they given? Well, very similar to the non-checkpoint antibodies. They're given intravenously, usually every 2 to 3 weeks. How long does it take? Again, similarly, you got to come in, park, see the nurse, see the doctor, get the drug thawed, then get the drug in clinic. So that's going to take most of a half a day at least. Do the medicines have to be taken, do any have to be taken before or after? Well, again, if you have a reaction, they'll give you appropriate medicines, but you don't need to particularly worry about it ahead of time. Are there contraindications to these medicines? Again, if someone already has an overactivated immune system, so they have a problem with autoimmunity, such as inflammatory bowel disease or Crohn's disease, then we really have to be very careful about using these molecules. It's not an absolute contraindication, but it needs to be very closely considered with your doctor. And are there any drug interactions with these medicines that you have to worry about? Well, with these drugs, we need to be very careful about immunosuppression. So these drugs have to activate immune cells. If there are immune dampening drugs on board, then we presume they're not really going to work. And how many doses and for how long do you need to take it? Well, this varies. Ipilimumab is given as 4 doses, but some of the other drugs are given as an open-ended treatment. And so this varies somewhat by each drug. So I'm going to sort of leave you with this, just to sort of emphasize how complicated really all this is becoming, and you're starting to learn a lot about how the immune system is working. So there are a lot of factors that can dampen the immune response. There are cytokines that are bad for the immune response. There are molecules in the tumor which can shut down the T cells even when they get there. There are other normal immune modulating cytokines that your own cells can secrete to shut down your tumor-fighting immune cells. There are also these inhibitory checkpoints we've talked about. And there are all these activating checkpoints. And all of these up here are potential targets for immunotherapeutic drug development and combination approaches in the future. So to summarize, there are multiple kinds of immunotherapy, and they vary in why and how they're given. Immunotherapy is becoming an essential part of the treatment for many cancers, as we heard about already. And the future is likely to include combinations of immunotherapies and possibly combinations with other treatments, which we'll talk about later today. And it's really an exciting time in the field. And I really appreciate all of you coming out today to hear about it. Thank you very much.